Awesome. Good afternoon, everyone. My name is Myles Jackson. As Teresa said, I am a first-year MHS student in the clinical trials track on the EPI department. And today I'll be discussing the main beginnings of my thesis and what I want to do for my research for next year. And my topic as of now will be the differential utilization of ambulatory care in the United States. All right, there we go. So before I delve into my specific thesis question, I would like to first discuss a few of the portions of my literature and research that guided me to my question and what made me pick this topic in the first place. So I'll be looking at some regulatory precedents that revolve around my specific subpopulation of interest. I'll be looking at some of the contraindications for my drug class of interest for my research, and also just some reasons why I believe that this question is important based off of these first 2 points. So first off, I want to talk about some regulatory precedents for my thesis. So the main drug class of my thesis that I'll be focusing on are NSAIDs. And if you're not familiar with the acronym, it stands for non-steroidal anti-inflammatory drugs. It's a common class of pain relievers that are used for many different pain relievements in modern healthcare. And I'm using this because this specific drug class over the past 20 years has shown an increase in risk for different subpopulations at high risk, particularly for those with cardiovascular and renal diseases. And given that it has the mechanism of action for its inflammatory properties, that has caused it to have some different interactions with those who have higher risk for maybe chronic kidney disease, heart disease, diabetes, end-stage renal disease. And this intersection was very important to me, and I wanted to look more into it. So as we can see in the top right, back in 2015, the FDA released a strengthening of their already in place black box warning for these NSAIDs on those who have increased risk of heart attack and stroke. And they saw this as, at first it was already in place in 2005, but because of the increase in research and results from different trials that have shown, adverse events from these NSAIDs, they decided to strengthen this warning in 2015. So that's just one piece of information that showed greater safety risks that have been alerted to the general public based off of the healthcare guidelines that were already in place a decade before. Likewise, in the bottom screen share, you can see the little New England Journal article that also showed some cardiovascular safety events that were associated with different NSAIDs. In this case, the trial showed celecoxib, naproxen, and ibuprofen for people with arthritis, and that was treated for their inflammation of their condition. But when they were given these NSAIDs, those who had higher risk of cardiovascular risk, they had the greater events from those prescriptions. And that just shows, another recent example of how cardiovascular events are increased or at greater prevalence once you have these NSAIDs at play. Likewise, in the top left, very similar situation, but in this case, looking at those with diabetes, they had increased AKI symptoms, and AKI just stands for acute kidney injury, along with hyperkalemia among those who had diabetes once they were given this NSAID. So along with stronger advisory warnings being put in place in recent years, they've also been translating this to more mandated precautions on drug package inserts for these manufacturers who are producing these NSAIDs. So in this case, we see Naprelin, Celebrex, and Mobic. These are just 3 examples of different NSAIDs that I found online, and showing just basically how, unlike them being now just in general before I continue, a contraindication in itself is just where a situation where a drug should not be used because the harm outweighs the benefits. So usually when there are contraindications, that's labeled in a separate section, as you can see in the first example, for specific subpopulations. And based off of the research I just explained, you would think that in many cases, these NSAIDs would be contraindicated for a lot of people who have these kidney or cardiovascular diseases already, because they're already at high risk for these events. However, as seen here, they are in a separate section of just warnings and precautions, which in many cases, can be lumped with things that are just kind of like a strong suggestion, or just kind of like a, it's there and we're going to mention it, but it's not on the same level as a contraindication. And in all these cases, however, they are very strongly worded with saying, severe or potentially fatal risks for all 3 of these. But I did have, a little bit of caution, in forethought of why is it not in the contraindication section versus just putting it within a precaution and warning section? Because there is a little distinct difference. So one reason why I believe that the research should be done on this differential use of NSAIDs in this subpopulation, I think that's important, is because of what's going on behind the scenes with other drugs already. in the overall umbrella term of analgesics, which is pain relievers. So in general, as we've seen the past decade or two, the opioid epidemic has become a skyrocketing issue because of their popularity and also their potential risks that are associated with them. So just some CDC data that I've pulled based off opioids in the past 10 years, 38 people die every day from overdoses involving prescription opioids. And likewise, within the past decade, since from 1999 to 2019, there have been, over 50,000 deaths, which is a 6 times increase of these deaths over time because of opioid overdoses. And that can be also graphically seen in that bottom left of just synthetic opioids and also others like heroin and other commonly prescribed opioids. There's just been a general uptick in all of this. So in general, why do I believe that this is, associated with NSAIDs? Like I said, they're both under the umbrella term of analgesics, which in this case talks about pain relief. And given that opioids have this very the pros and cons may be outweighing each other in terms of the harm may be too great for what the drug does offer. NSAIDs could definitely be another alternative for pain relief that is offered to these patients who need this chronic pain treatment. And from this meta-analysis we're seeing here that I pulled from, something about this conclusion was very important that I wanted to bring up, because within this meta-analysis, they were talking about joint pain and just relief for pain relief in that regard, but they were comparing NSAIDs to opioid treatment and the effects of both. And one thing that I want to point out from this, it's right in the middle, the second or last sentence, talking about diclofenac, which is the NSAID of interest in this meta-analysis. They were talking about different dosage levels of it and how when they knocked down the dose to a certain level, they were able to show greater effectiveness based off of reduced systemic exposure. So that in itself shines NSAIDs in a more, promising light compared to how they are talking about opioids in this discussion, where if you look further down to the last sentence, it says basically the clinical benefit of opioid treatment, regardless of preparation or dose, does not outweigh the harm it might cause in patients with, in this case, osteoarthritis. So in general, this allows for somewhere of a gray area in terms of pain treatment for these different drug classes. And in general, how, it kind of leaves, in general, the decision for prescriptions of these NSAIDs in the hands of healthcare providers, which in many cases, they may not have the full breadth of the knowledge and, time and resources to look into all the different risk factors available to them for prescribing these drugs, which, at that point leaves people who have these at-risk populations at greater risk and really at the hands of just people who may not have really informed decisions. And likewise, you can see with certain studies like that in the past, comparing opioids and NSAIDs and other types of chronic pain treatment options, that has allowed for, in recent years, guidelines to be in place for these drugs to maintain status as a first-line analgesic. And in that case, first line, that's a really strong claim to make for something that may have very strong adverse events among people with cardiovascular and renal effects. And this is just one example of that I pulled from CDC guidelines from their website directly. And again, this is from 2016. So it's still, it's not as recent as that meta-analysis I just showed you all, but it still is the most up-to-date guidelines as of now from their website, talking about, non-opioid medication options that can be used in response to, this epidemic that's been happening. So as you can see, acetaminophen and NSAIDs, gabapentin, all those are seen as first-line agents for treating chronic pain. And yes, they do outline the harms that are in place for, cardiovascular or renal, adverse events. However, they're still seen as first line, even with all the research and stuff that I just showed, just a little tip of the iceberg of it. But all the research that's already in place that shows these adverse events at very high risk for these people, they're still seen as first line pain relief. So that was concerning to me. And I felt like that was important to understand, what is going in the process of prescribing behaviors for looking at these different prescriptions. And if for people at risk, especially those with cardiovascular and renal events, what is going into the minds and the factors at play to understand who is getting these medications and when. So that brings me to my main question for my research overall across all my different aims is there any differential utilization of this ambulatory care in the United States based off of cardiometabolic risk? So basically from this main question, I'll be dividing my thesis into 3 different aims or 3 different research goals. My aims 1 and 2 will be risk factor analyses used to inform to inform which variables I will include in my causal analysis. And that will be also broken up into two different types of causal analyses. So the first thing we'll be focusing on variations in the prescribing behaviors among high-risk patients, and it'll be based on different identifying characteristics. So in this case, I'll be looking at NSAIDs and using acetaminophen as a comparator drug. And I'll explain more why on that later on. And then my second one will be focusing on the variations in diagnostic services being administered to those high-risk patients as well. And then I'll be looking at the same kind of patient characteristics to determine which ones are influencing those decisions the most. And then for my causal aims, I'll be focusing on if there's an association between the level of cardiometabolic risk and the likelihood of them getting either a prescription or a diagnostic service in a causal effects association. So my primary source of data for this analysis will be from the National Hospital Ambulatory Medical Care Survey, also known as the NHAMCS. And that is a publicly available data set that is housed within the CDC. And its main purpose is to describe the patients that utilize emergency department care services, the conditions that are being treated the most, and any of the therapeutic services that are being serviced to people when they come to the emergency departments. And that also includes which prescription drugs they are given as well. So this survey is done annually, but because of the nature of an emergency department visit, every year there's different populations included. You can't really follow people across time points. So it really is just cross-sectional in nature. And they collect this annually since 1992 within a 4-week reporting period every year. So all the data collected is for that year, and they just follow that in a serial kind of way, cross-sectional kind of way each year. And along with this, you can't really look at participants from one point in time and the other, because the sampling unit is a patient record form. And a patient record form in itself is just talking about, it corresponds to only one ER visit in total. So versus it coming from like a patient ID standpoint, we're looking at it just as a patient record form. So the only time that data is collected on that particular individual is at that visit and not following them any kind of way afterwards. So from that, some other things that are collected while you're within this patient record form are patient demographic information, their insurance status, vital signs, chronic diagnoses they may have at the visit, some medications that are prescribed, diagnostic services administered, obviously, as well as just any logistical details about the department as well, which could include what physician is seen or how long the visit was there a follow-up visit planned? So all these things are also included within the survey as well. And although there's almost 3 decades worth of information from the NHAMCS, just for this presentation alone, I will be only focusing on the year of 2018. And from that year of the survey, there was a sample size of around 20,000 people. And it includes all the patient records from that year. So following the data collection, I had to determine what my main stratifying exposure would be for my causal analyses and what I'd be, delineating high or low risk for. So basically what I chose was for high and low risk of a cardiometabolic disease. And from this definition of a cardiometabolic disease, I got from the University of Edinburgh. Their College of Medicine kind of explained it pretty well, and I like this definition pretty well. It is defined as a group of common but often preventable conditions, including heart attack, stroke, diabetes, insulin resistance, and non-alcoholic fatty liver diseases. So based on that criteria, it's a pretty nice umbrella term that was able to, based off of what the information that was given in the NHAMCS, I used the diagnoses that they recorded and measured for and delineated a clear dichotomized yes or no of high or low risk. And anyone who was high risk, I had these specific diseases at their ER visit. Anyone who was low risk, I had the ones listed here. So as you can see, I have, a lot of kidney and heart diseases that are pretty prevalent and common, as well as including some like obesity, alcohol misuse, and then HIV infection and substance abuse. These were chosen solely because of just some of the research that I did on them, and that they had a direct impact on risk for cardiometabolic diseases. For alcohol abuse, for example, that one had a direct association with insulin resistance, as well as HIV infection had an impact on the kidneys, and then substance abuse had an effect on like cardiac issues. So that's why I picked those as well, alongside the other like cardiovascular or renal diseases. And then as you can see with the other ones, these also just didn't have a direct line of, association with higher risk. That's why they were input in low risk. Along with that, I also dichotomized the presence or absence of an NSAID prescription based off of the prescriptions that were present in the NAHAMSE survey. So I pulled this full NSAID list from the FDA website of just all that are approved on the market right now. And then I just kind of narrowed that down and condensed it to a list based off of what was present in the survey. So these are the drugs that were part of the survey. And basically, if there was just at least one of them present within a patient record form, then I classified that as having an NSAID, and then 0 is the other way if none of them were present, basically. Oh, and in the same manner, I did the same thing for acetaminophen, since that's the comparator drug. And I chose acetaminophen because they also are an analgesic that has pain relief, but in the same breath, they don't have the inflammatory property, which is what causes that extra risk level for people with cardiovascular or renal diseases. So that's why I chose that as a comparator control group if they had that prescription. So the research question for my first aim is, among those at high risk for cardiometabolic diseases, are there biological or demographic factors associated with an NSAID prescription at their ER visit? So to the right, I have made a conceptual framework for this risk factor analysis and included the patient factors that I believe were most important in influencing prescribing behaviors at the ER visit. An important thing to mention that I really wanted to see was like both joint and individual effects. So for example, patient race and ethnicity, patient age and sex, they do have their own sole effects, but also I saw a joint, I wanted to see if there's a joint effect between like race, ethnicity, and age and sex as well. Along with that, I included like the patient's urban classification, as well as their expected source of payment for whatever kind of ER visit or services they were given while they were there. So that would be classified as their insurance type. And that just was how it was classified in the data. So I included all of these as different exposures for the main outcome of interest of probability of either having an NSAID prescription or not having an NSAID prescription. And this is all among people who have high risk for the diseases. And just from here, we can see these are some frequency tables that I made from the data. And it's showing, it's categorized or stratified based off of the different diseases within high risk. And I did it for those who were given an NSAID prescription, those who weren't. I just wanted to point out just some numbers that I saw were like striking as like the biggest people who relatively got the most NSAIDs overall. So in this case, it would be people who were classified as obese compared to those who had end-stage renal disease. There's a stark difference of people who didn't get some NSAIDs and some who didn't. And likewise, I did the same thing for acetaminophen in the same manner. So you can see that the ones that are highlighted are some just numbers that kind of stuck out to me. So the research question for my second aim is also risk factor analysis. And it states that among those at high risk for cardiometabolic diseases, are there patient level or physician level characteristics associated with receiving a diagnostic service and planning a follow-up visit? And there's another similar conceptual framework made in the same way. I will say though, since even though I did have planning a follow-up visit in my question, I didn't put it in the framework because I didn't want to put it as a second type of outcome. The main outcome is the diagnostic services, but I felt that there was an association and some kind of, me and Dr. Shriza talked about this, about having that connection between the diagnostic service and the follow-up visit being planned, having some kind of connection there. But the main outcome of interest is the diagnostic service being performed. And basically in the same way I see some joint effects here that I wanted to point out, in the same way of the age and the sex, race, ethnicity, as well as some characteristics about the emergency department, looking at maybe like the metropolitan status of the ER that they're at, what kind of hospital ownership versus like private, public. There are some other ones delineated in the survey, but just seeing if there were some differences there. And likewise, the type of provider seen. So like a doctor versus like a nurse practitioner, like PA, stuff like that. So that was also, described in the survey. And I thought that could be interesting to see if there was a reason or some kind of connection between that and what kind of service was performed on their patients. And likewise, I included just a list of the different frequencies for the different types of services that I wanted to focus on. Basically, there was a list from the survey of different types of services that were provided. All the ones that I chose here were ones that I looked up and researched and saw that they could be, associated with, screening for people who have these high risk diseases, whether it be renal or cardiovascular, and they all, fell in line with what I believed were important to include as a type of diagnostic service provided. And the highlighted numbers are just some extra ones that I saw that stuck out to me again. And likewise, like I said before, both of those two causal or risk factor analyses will be to inform what is included within these causal analyses. So obviously the ones that I have here, like the white circles are, they represent controlled confounders, but that could obviously change depending on what my results are for the first two. But for my first causal aim, my question is that if there are any association between a patient's risk level for a cardiometabolic disease and their likelihood of being prescribed an NSAID. So I have all these proposed confounders, and then risk level obviously will be dichotomized, as I explained earlier, between being high risk or being low risk. And then the prescribing behavior will be similar to the first risk factor analysis of having an NSAID or not having an NSAID. So both binary in nature. And all of these different variables will be controlled for. I did want to include, regardless of what the risk factor analysis is, the presence of concomitant medications or comorbidities, because I feel like those are very important regardless of, just including in general, regardless of whatever else happens with the other risk factor analyses. So all these will be controlled for, and seeing which ones, could influence more, could influence less. That's to be determined. Still early on, I haven't done much yet, but I think these are just a good little, foundational amount to include for now. And in the same way, I included these frequency tables to discuss just kind of where differences lie within the high and low risk categories. You can see the sample size included for both. And I'm still, the inclusion and exclusion criteria for these are still, not set in stone. So any input on this later on, you're welcome to bring up with these different tables that I'm showing. But as of now, this is what I've done just to delineate the differences between the high and low risk. And I highlighted just showing which ones have shown, again, the highest levels of NSAID prescriptions versus the lowest ones. And I did the same thing for acetaminophen as well. And for this, I'll just be showing the dichotomized difference between high and low risk for NSAID prescription. In the same fashion, it will be done for diagnostic services. So the question will be, is there any association between a patient's risk level for a cardiometabolic disease and their likelihood of receiving a diagnostic service? So the same variables were included as confounders. And I still, have yet to determine which ones are going to be important or not. But as of now, these are ones I'm including. And in the same way that I've done the dichotomized exposure, it will be the same way for this causal analysis. But for the outcome, as we see here, the outcome will not be dichotomous for the logistic regression that I plan on doing, because each one will be a type of category for the diagnostic services. So I didn't think it would be smart to just do a dichotomous, a presence of one service is a 1 and none at all is a 0, because that just would not be, given how many tests you could get, it didn't make sense to make that dichotomous, in my opinion. So that's why I'm choosing to do it by each category as one. And that will be the main outcome of interest for each single one. So from that, you can see here, I did it for high and low risk as well, and highlighted what I felt was the, just numbers that stood out to me. And that's that. And then from there, I went on to talk about my data analysis. So for my analysis, I am looking to do logistic regression for all three. As I stated before, there could be a dichotomized exposure and outcome for both of my risk factor analyses. Dichotomized exposure for my risk factor analyses for both of them. But for the outcome, the differences will lie within what the outcome is. So for the prescription of NSAIDs, I saw that as a dichotomous outcome. And like I just explained earlier, for the diagnostic services, I want to make that nominal in nature because there is no real, value of one over the other. However, I think that it's important to have each one delineated separately within the regression versus just putting it all within a binary. So that's why for aim 2, it's going to be a nominal logistic regression versus just a regular simple logistic regression for my first aim. And likewise, the same process will be done for the causal analyses as well. Looking at different, metabolic risk as the main exposure in both cases. This is just a little bit of my works cited and what I, talked about through all the rest of my presentation. And just in general, there were just some of the things that I want to take some feedback on. Obviously, again, this is still very early on, and this is just the main framework so far of what I kind of have been trying to parse out through the data. But I would love to give any input or any feedback from you all on the following things, because these are things that I'm still not sure on yet. So as I stated before, the risk category, like classifications and descriptions are not set in stone. So obviously with people who are high and low risk for cardiometabolic diseases, it does depend on the definition. And I feel like that definition that I picked, that could be tweaked. It could be picked. You could find a different one. But I would like to know if you all believe that that is it suffice, or if there's anything else I can add to maybe refine it a little bit and maybe fine tune what I choose to put in what. Um, Also, I would like to see if you all believe that the stratification based off of the type of NSAID, whether it be like a COX-2 inhibitor or other types of NSAIDs within that class, would be important to bring up, because I do have, like the list of drugs, but I just kind of put it all under a blanket term of an NSAID. So do you believe that maybe adding some kind of stratification along that would be good? Or also grouping together diagnostic services based off of what they are testing for. That's another thing that I was thinking of. And likewise, as of right now, I have about 10 years of data, like in my like actual data set that I'm looking at between like 2009 to 2019, something like that. But I'm obviously not sure where I should include, cutoffs for certain numbers and certain years. So if you all have any input on what years I could probably include, I was thinking more of like maybe regulatory guidelines for NSAIDs and like if that could play a part in it. So if possible, I might include that as well. And just some other things about the clinical feasibility of this and any value that may be that you all can impart upon that. I'm open to any and all suggestions. But yeah, as of now, that is everything. And I'm open to any comments right now.
Thanks, Myles. Anyone have any questions or so? One thing occurred to me when you were going through the presence or absence of each of the exposures. Had you thought about counting the NSAIDs as opposed to just presence or absence?
So doing it like as a value.
Yeah, potentially.
That could be a thing, yeah, for sure. Because I feel like, with just having as a binary, that does kind of restrict to only just one or the other. But it's definitely possible that that could be something to look at as well.
Mm-hmm. Or perhaps even by the number of classes.
Hmm.
Any other comments?
So just a couple. NSAIDs could be used short-term for relief of pain or long-term for release of inflammation. And one thing that you probably ought to be looking at is those inflammatory diseases such as arthritis, where there would be more likely to be long-term work. The second is long-term use. The second is that the cardiovascular risk, at least in the first studies that led to its identification, suggested that you didn't see it until you had been on long-term therapy, perhaps more than a year. And so you didn't see the increased risk. And so I want to echo the previous statement that yes, no may be too simplistic, and you may need some sort of category as to duration if you can get those data.
Gotcha.
Any other comments about the drugs that were included, or perhaps the clinical diagnoses that were included in the disease areas? Alrighty. Myles, if you don't have any other questions to pose to the group, I think we can tie up for today.
No, that's it.
Great job. Thank you. Thanks, everyone. We have one more RIP this year in May, so look forward to seeing you all then. Take care.
Bye-bye.